Good morning again, everyone. I'm Dwayne Spencer, President and CEO of Habitat for Humanity here in Memphis. So welcome back to our Health and Housing Summit webinar series. I want to first start by thanking our sponsors who helped make this event possible. The Tennessee Housing Development Agency, Wells Fargo, and Methodist Le Bonheur Healthcare. And a thank you to our event advisory group for offering their expertise. So yesterday we had an amazing conversation on the social determinants of health and how these indicators influence the decisions of hospitals to invest in programming outside of the physical walls of their institutions. The day before that, we heard the healthcare case around public-private partnerships and how innovative solutions for populations could be arrived at. Some of what I took away, I'll share those with you. So first, health begins long before you enter the doors of a hospital. Hospitals have both financial and political influence in their communities, and we need to tap into that. Hospitals already have a mandate to invest in their communities, but will, initiative, and innovation can really impact what can be done via creative partnerships with community development organizations. Anchor institutions like hospitals can be motivated. We need to better understand their value propositions. Value-based contracts with payers is an essential. Care transformation and how care is delivered matters. As our friend Tom Osborne said, there's nothing wrong with big, audacious goals. Dr. Peggs reminded us that keeping people in their homes is some of the best medicine. So I thought, wouldn't it be amazing if gerontologists like Dr. Peggs could actually prescribe home improvements for seniors to address health-related issues that could be mitigated right there in their homes. Person-centered interventions are always an imperative for holistic impact on the senior's overall health and well-being. Our healthcare systems don't pay for aging in place, yet they are a beneficiary of that work and its impact on reducing senior health-related costs. And financial incentives are misaligned. Success will be based on combining models and incentives. And so with all of that, at the end of the day, the common thread was partnership. And so we know that no one organization can meet the need, the total need, and no one organization can sustain the cost to do this work. It takes partnerships between nonprofits like Habitat for Humanity, hospitals, health systems, payers, community organizations, and of course, philanthropy. Philanthropy to date has played the most pivotal role in supporting our efforts here in Memphis, and I'm sure for many others around the country, in providing those life-changing services to seniors, and remains vital. But it alone cannot sustain the work, and we need to pivot to a more diverse pool of resources where philanthropy is only one of several means to support these ongoing efforts. So philanthropy is what we will talk about today. So again, I want to encourage you all to continue to use the chat feature, use the Q&A function to send your questions for the panel, and then feel free to tweet and post about the event. And if you do, please use the hashtag, TN Health Housing Summit, or just Memphis Habitat. So today's moderator is our friend Diane Oliver, Executive Director of the West Home Foundation, a Nashville-based private foundation. The foundation's mission is to enrich the lives of older adults through grant making, advocacy, and community collaboration. The foundation awards approximately $2 million annually to nonprofit organizations serving older adult populations in Middle Tennessee. The foundation is also actively engaged in advocacy to raise awareness of aging issues in the community, to build greater capacity among direct service providers, and to leverage other resources for support of aging-related services. Under Diane's leadership, the foundation played an instrumental role in leveraging, for the benefit of aging services, $40 million received by the state of Tennessee from the settlement of a court case involving the dissolution of 2 nursing homes. Memphis Habitat is the beneficiary of those funds. And Diane currently serves on a statewide consortium that provides oversight to the new and innovative aging initiatives that are significantly expanding services for older adults in both rural and urban communities across the state. Now, I'll turn it over to Diane Oliver.
Thank you, Dwayne. I appreciate that kind introduction. I just want to say good morning to everybody and welcome to today's program. It's great to see so many of you coming out for logging in for this morning. We're very excited to be here. As Dwayne said, our focus this morning is on philanthropic partnerships, the value of health and housing investments. I've been involved in the aging space for a good part of my career and feel very privileged to be part of this movement in the Tennessee area. We're located in Nashville, but serve all of Middle Tennessee. And as Dwayne said, we're involved in this statewide initiative, which I'll talk a little bit more about later. But our foundation funds a broad range of services, including a number of programs that address the issues associated with health and housing. And I got very excited about being part of this conference that is kind of bridging those two because we can't look at them separately any longer. Health and housing outcomes for older adults are vitally important areas of investment for grant makers. Historically, I think we've looked at health and housing programs separately, and they've often had very different funding streams. But as I said, the two are very closely related. So the evolving needs among our older adults are going to require innovative, integrated approaches and investments to effectively serve the number of older adults who find their health is becoming negatively impacted, but they want to remain in their homes and in their communities. And it's exciting to see so many new initiatives addressing this area. In today's panel, we're going to learn more from leaders in health and housing philanthropy and the next steps that we all should take in scaling and sustaining this pivotal work. We have 3 excellent panel members here this morning, and I'm just going to briefly introduce them. And if they can start their video and give you a wave as I give you their names, that would be great. The first is Earl Millett, Program Director with the Harry and Jeanette Weinberg Foundation. Earl manages grants in the area of health, and I believe you're joining us today from Baltimore. Is that right, Earl?
Correct.
Second, we have Fred Carness. Fred is a senior fellow with the Richmond Memorial Health Foundation, where he supports the foundation's efforts at the intersection of health and housing. Good morning, Fred. And last but not least, we have David Fukuzawa, Senior Advisor to the President of the Kresge Foundation in Detroit, Michigan. And David has led the effort to re-envision and redesign Kresge's approach to health grant making. I want to thank you all for being part of the program this morning. I'm excited to hear what you're all doing in your communities. And I'm going to let Earl Millett kick things off. Earl, can you share more about the Weinberg Foundation and the work that you're doing around housing for older adults?
Absolutely. Thank you, Diane, and thank you to everybody who's put together this wonderful conference so far. And I'm honored to be a part of this panel where I'm actually interested to sit back and listen to and learn myself from some really great presenters who have a lot of experience in this field that really is important to all of us and needs to be taken in more importance by a lot of folks. So yes, Harry and Jeanette Weinberg Foundation just celebrated its 30th year in operation last year and has always had a focus towards older adults. In general, the focus is on health, housing, education, and jobs. And we have focus areas in communities in Maryland, Northeast Pennsylvania, New York, San Francisco, Chicago, Hawaii, and Israel, all hometowns or areas that are tied to the founders in some way. But outside of those focus areas where we do education, jobs, health, and housing, as I mentioned, we have an exception, thanks to the trustees, for older adult capital projects. Half of the money that the foundation gives out annually, and the foundation gives out approximately $125 million annually, has to be in the form of capital because we recognize how important putting the infrastructure in place and long-term that can be to provide just the basic necessities, or I should say the founder and the trustees do. And through that, what the trustees have long recognized is the lack of support for those type of projects nationally. In fact, studies by the grantmakers in aging have shown that less than 2%, and I think we can even go, unfortunately, we're getting even closer to 1% of philanthropic dollars go towards helping older adults. And that's just a shocking number on the face of it. Currently, 65 and older adults in the United States represent 15% of the population. And they don't lose the need or the deserving of support just because they've become older. But I'm preaching to the choir to everybody on this call, I'm sure, about that. So in that focus, the foundation has looked for programs that are able to provide that support now because we've talked in this field for decades about aging population growing. That 15% I mentioned is only going up. And that time has passed about talking about that. That time is now. So establishing programs that can provide support and help to those older adults now is crucial. Within health and housing, we do the traditional housing programs, especially capital nationally, that you would consider: building affordable housing, building food banks, access to food, access to nutrition, helping support those projects. But the foundation has long recognized the connection to health and housing and used to fund a number of assisted living, skilled nursing facilities, all very necessary and important, and we're very proud of that work. But a number of years ago, switched to focusing on aging in community. And really, as everybody knows, that's a little bit more than aging in place, or a little different. Aging in place just means keeping folks necessarily in their exact place, at least our interpretation. But community means they can move. You can downsize. You can move to affordable housing, but you want to stay in your community, connected to other resources, connected socially, connected to economic supports. Those are all just as important, more important than necessarily the physical structure, though we all know that older adults prefer to stay in their exact homes. So there's a number of programs that we have supported nationally, and I'm happy to take questions on them and speak more about them if everyone wants to hear about them, but I wanted to highlight a few. The main one that brings us here today is the CAPABLE program, Community Aging in Place, Advanced Better Living for Elders. But everybody knows it as CAPABLE, and if you've listened to any of the presentation so far in the previous weeks, you've heard experts speak much better about the topic than I could on the details on how it works, but I'm always happy to talk about it. I actually worked with one of the nonprofits that did the home repair work back in 2007 when it was a pilot program. And that's not a time in which the Weinberg Foundation would have come in. If you speak to one foundation, you've spoken to only one foundation. Everybody's different. But Weinberg kind of wanted to see that that was something that was actually helping seniors. And those initial pilot programs really had that data and metrics, and started with the idea of data and metrics before they began doing the work. Kind of coming at it afterwards is always harder and doesn't produce the results you want. So they really looked at it, as was presented in an earlier presentation early on, and were able to show Philanthropy that this can work. And then more importantly, they were able to show to sustainable funding sources. Very few philanthropic funders want to fund something forever. They want to help grow programs that are going to help. They help start in some cases. They want to expand, but the question that you always get, and I have worked on the other side, applying for grants, as well as now on the philanthropic side, what is your plan for sustainability? And unfortunately, we don't accept the answer of finding the next philanthropic partner to keep funding us, though we know how important that often is. And what Capable was able to show was that they are moving up through PTAC, through Medicare and Medicaid, different funding sources to become reliable. And really going to what Dwayne said of who is going to see the savings. The reason Philanthropy is interested is because the older adults are going to see better living in their homes, safer living in their homes, better health outcomes. They're going to stay connected to community, as I said. And unfortunately, we have learned in this past year, though it has worked out as expected, survivability of pandemics, which nobody could have necessarily predicted, are better when individuals are able to age in community or age in place. So being prepared for what may come. But who's going to see the dollar savings? And that's healthcare companies, that's hospitals, and that in the case of healthcare, it's Medicare and Medicaid. So getting those programs on board to provide the sustainability. And if the foundation can help support getting those going, and the Weinberg Foundation has supported specifically with Memphis Habitat and others around the country with Capable, that capital piece where the trustees have been unique to accept individual home repairs of individual older adults to make their home age friendly as a group capital project. If you take a group of those, put them together, we will fund that as if it was a capital project, as if it was a building, because we don't want to fund what's easy for us. We want to fund what the client wants. And we all know that we've heard, while we need affordable housing and apartment buildings, those exist and are important, we also need to meet older adults who do not choose to go that route and want to stay in their homes, and will stay in their homes even if those homes are unsafe for them as they age. So that's the point at which we can provide the support for capital and have supported Capable. The other last thing I will say on Capable, unless I get more questions about it, which I welcome, is Capable has a diversification of their platform, how it can work in community by community. There is a need from us as a national funder. I don't live in Tennessee, unfortunately. I've been able to travel there once and meet and see the wonderful programs that Memphis Habitat is doing in partnership with 10 Care. But we look to the local partners to tell us, what do people in Tennessee, older adults, want? I don't presume to know what they want and how they can be met. One iteration of Capable that the foundation works with uses social workers more than nurses. Habitat obviously comes at the issue of home repair a little more forcefully than maybe another partner we have elsewhere in the country, that where it comes from a medical group that's coming at it more from the nursing perspective. And that's fine, because tailoring it to the individual needs is important. And we look to see that in the applications, as well as the partnership with the hospitals for sustainability. And then finally, we are looking to fund programs that can find the most vulnerable of populations. So low-income older adults need this support, deserve this support, will benefit the whole community by their increased interaction and remained health in the community. They're not just receiving charity. They are an integral part of community and necessary to have a neighborhood successful for all ages. But there are veterans who are harder to accept support. So Capable focusing on veterans is a program we're interested in. There are older adults who have experienced or are experiencing homelessness, a difficult group to outreach to and connect to. So programs that can bring this program model, which will hopefully, but we expect to be sustainable one day, to those individual priority groups is so important. Another program that we fund out of the health priority, not the housing as much, is PACE, program for all-inclusive care for the elderly, called a few different things in different states, but in Tennessee as PACE is a very exciting program based around providing what the older adults need as far as all of their healthcare needs, being a day center, if that is what they need, coming to get them at the home, but basically taking on the agreement to provide all the medical care and other social interaction care, access to arts and activities of an older adult. And for that, they really see the savings by kind of doing that as a group work. They'll take on 100 to 250 to 300 in area. They need a center in which to do it, and Medicare and Medicaid will pay for the care of all of those. And some of the members of that group of 200 older adults, say, will spend more than honestly the PACE Center is receiving, but some will receive less, and it's balanced out to a sustainable program. Currently, this program exists to about 55,000 older adults nationwide. Way too few for a program that started in the 1970s in San Francisco with OnLock. So why isn't it grown more? Well, there's a huge investment to get it started, and that's a place where philanthropy can come in, helping with the building of these centers, getting them started and off the ground, along with loans and typical tax credit products that help get them started, because generally within 3 to 5 years, they're fully sustainable. And we really feel like all older adults, low incomes, the ones we're focused on, should have access to the services, the complete, comprehensive, meet the individual where they are services that can be provided. And they allow older adults to age in communities we talked about, being located near affordable housing, being located in communities of low income housing where older adults can stay where they are currently housed. And really, we're working hard to help that grow along with the National PACE Association. And we always welcome connecting folks up with that if they think their community needs that space. And thank you, Dwayne, for putting a better definition of capable in the comment section. I did kind of gloss over that and how it works with, again, it varies with different programs with month intervention, nursing, occupational therapy, and home repair, and the data around that. But I welcome people to ask questions or look up more about that. Moving on, the last area I would just say is always making sure to recognize unique populations. I think that's been a theme of what I've talked about here from a national perspective, and that includes housing, as we talked about, that we fund in the capital space, and focused housing for individual populations. The one area we're focused on right now is LGBT older adult housing. Older adult housing that is either existing and being trained to be more LGBT friendly, or housing that's built specifically with that goal in mind. Unfortunately, we've come a long way, and a lot of individuals have been able to express how they want to be identified, but then as they become older adults and move into affordable housing, they are forced to not do that anymore because of a lot of different things. I will note that following the recommendation of SAGE, which is Services for Gay and Elderly, based out of New York, that does national programs, but they just go by SAGE, I use the terms LGBT because the Q, which many people use, is a controversial one in the older adult community a little bit, because there's still a lot of biases. There's a lot of biases throughout community, but specifically in the older adult ones. And sticking with LGBT is the more friendly term that can work in buildings, but still a lot of work to do within that group and population to be accepting of all individuals that deserve service. And so kind of that focus on a very specific, often forgotten population that deserves specific highlighting and support is something that I think the philanthropic community can step up for. An older adult affordable housing complex, a capable program that's a standard one, can have access to a lot of different government funding. Dwayne mentioned the nursing home sales that led to some funding in Tennessee, but where you need to add a focus to a vulnerable population or starting a partnership for sustainability, those things is really where we feel like philanthropic need can come in, and one of the reasons why we do it nationally and trust our great partners locally who are able to let us know what the individual needs are. So I look forward to more conversations on the equity issues, social isolation issues, and different ways that nationally can be funded capitally. But I'm more excited to listen to my colleagues who have a more local approach. And Diane, turn it back over to you.
Okay, Earl, thank you so much. That was incredible information, and you all are doing just some amazing work. Next, we have Fred Carnus. Fred, can you tell us about the Richmond Memorial Health Foundation and the work that you've done around social determinants of health? I just want to note that your largest body of work has not focused exclusively on older adults, but your learnings are certainly transferable and can help inform strategies targeted to older adults as those evolve. So I'm going to turn it over to you.
Great, thanks, Diane. And great to be part of this conversation, not just today, but the whole series of conversations that you've had, I think are just so critically important. And I'm particularly glad to, from a personal standpoint, my wife grew up on the Virginia side, not too far from Bristol, and my daughter worked for SOS and Binghamton CDC in Memphis and still owns a house in Memphis. So I feel connected to Tennessee in some ways. And it's good to be on the panel with you, Diane, and with Earl and my old friend and colleague, David. I have to say, it's a little daunting to follow Earl's presentation about Weinberg, because they've been such a leader in philanthropy around aging, and just to see what they've been able to accomplish and what they're working on is just exciting. I'm going to bring a perspective from a much smaller foundation, a local regional foundation called Richmond Memorial Health Foundation, based in Richmond, Virginia. We are about a 20-year-old health conversion foundation, created from the sale of a hospital here in Richmond. We have a total corpus of around $75 million and put $3 or $4 million on the street each year. I think that's 2% of what Weinberg does, and even less percentage of what Kresge does. But hopefully, as we talk today, I can talk a little bit about how even as a small foundation can have an impact at this intersection between health and housing. And we started out as a traditional sort of health conversion foundation, funding hospital equipment, special programs in the healthcare world, sort of basic needs in clinics, transportation programs around health. But over the years, we've evolved to a sort of different perspective. We still put a significant amount of money into the sort of healthcare safety net clinic world, but we've begun to refocus over the last 5 years really on upstream social determinants of health, as was mentioned. As we've seen that the health outcomes for many folks across populations, but particularly low-income communities of color, are not going to be improved simply by the healthcare system. We've got to look upstream. And in addition to sort of focusing on health and housing, which I'll talk about in much more detail in a couple of minutes, we've also begun to engage in much more advocacy, community organizing, power building, and focus on Black and Brown-led organizations in our community. And we're deeply committed to engaging those who are being most affected by the social determinants of health in the conversation, making sure they're at the table as we plan and work, develop this work. So what can a small regional funder do at this intersection of health and housing? Well, first, a couple of caveats. Because of the size of our corpus and the amount of money we put out each year, we don't fund any bricks and mortar. The $2 or $3 million we put out each year probably wouldn't fund a single project by itself. And as Diane mentioned, we have not in recent years focused particularly at the intersection of health and housing around seniors. Although we're beginning to have some work, I'm actually convening with a couple other funders, a group that's starting in the next couple of weeks to begin to talk about older adult issues broadly, and of which housing will be one of them. But I do think there, as Diane said, I think there are a number of ways that a foundation of our size can have an impact. So what have we done? Well, the first thing we did is began to take a look at our internal work around health and housing, began to sort of look at what the needs were in the community. We convened a national advisory board of experts from across the country and brought them to town. David Fukuzawa, who you'll hear from in a few minutes, was part of that group, and began to sort of look at where were the areas where we could have an impact. We identified 5 areas. So I'll list the 5 areas, and I'll get into some examples in a couple minutes. First of all, data development and planning. Second of all, building for a better health and housing partnerships. Building infrastructure around sort of the bigger issues to tackle the issues at the intersection of health and housing. capacity building for organizations that were working in this space. And then finally, program-related investments as a tool to support health-related housing interventions. So, as I said, let me get into some specific examples. Around the debate of development and planning, we invested in the Richmond Regional Housing Framework development. It was a very broad effort across our region to take a look at the affordable housing needs of all populations. And there was a particular section focused on older adults and what their particular needs were in our region. But it also set as it suggests in the name, it set a framework for us to, as a community, to be working on around affordable housing. We also invested in a market study that was done for us by a firm out of Philadelphia that looked at our housing market and helped us have a better understanding of where there were communities that were being left behind, where there were hot neighborhoods that were beginning to displace folks of all ages, but particularly seniors, and then where there were growth areas. So as we began to target our resources, we could begin to look at where we could have the most impact. So that was one area. Another area was building infrastructure for better health and housing partnerships. And this is sort of more on the ground work that often sort of local and regional funders do. But we funded medical, school, and nursing partnerships with senior housing projects to make sure that they were getting the health supports they needed in the settings in which they lived, very much tied to aging in place and protecting that ability. And it's been very critical, obviously, during the COVID time. Another area which we just got engaged in over the last year as a result of COVID, but I think will be an area we'll continue to stay involved with, is funding audio and video technology equipment so that, again, we can bring health services to folks in their homes, particularly in senior housing projects, so they can have dental appointments and behavioral health counseling appointments and physical health appointments by video in their settings. And it's really made a difference for folks who couldn't go out because of COVID, and hopefully beyond COVID we'll be able to provide that service. Also building the community infrastructure to tackle issues. And as I said, this is a more macro look at what we've been able to fund in the community. One of the areas we've focused on is public housing. And I think no matter where you're from, you recognize that perhaps the most vulnerable population of your city is living in public housing. And many of those are older adults. And unlike probably a lot of other places in Richmond, depending on the neighborhood, there can be a 20-year difference in life expectancy, folks living in public housing versus living in other more resourced neighborhoods. And so we brought together public housing folks, city government folks, nonprofit housing providers to sit down and say, how can we engage better to support the folks who are in public housing and also help those who choose to move to other settings to be able to do that. And we're really pleased that the city has taken that over as a primary project of some of the work that they're doing. Similarly, in the area of the health impact of eviction and displacement, something that's really concerning to us in some of our hot neighborhoods where historically African-American neighborhoods, where seniors who've lived there for years and years, even though they may have paid off their house, are now being pushed out of the neighborhood because the taxes have increased because of the value of properties. How can we engage there? Working on land trusts, working on land banks, working on home adaptation to allow either accessory dwelling units, perhaps as another source of income, or just fixing up the home so that they can be able to stay there. Then moving to capacity building. We recognize that some of the folks that are doing the best work at a really small scale are often embedded in the neighborhoods, and they're often smaller organizations that are working on housing in a whole array of, all the way from housing development to the whole issue of housing counseling, eviction counseling, or eviction remediation. So we've invested in those, particularly in Black and Brown communities, which are deeply impacted and have often been ignored by philanthropy. And similarly tied to this is the investment I talked about earlier in our sort of advocacy work, power building work around housing issues, as we've tried to reach out to broad voices, not only in Richmond, but statewide here, to raise these issues in an important way. And then finally, PRI, program-related investments. And as for those who aren't familiar with those, these are investments from philanthropy that don't come from the grant side. They're actually loans, but they're often very low interest loans, and they're often, hopefully, willing to take on more risk than a bank is often willing to take on, as a way to move a project forward. And even as a small foundation, we've been able to invest a PRI with the enterprise community partners and the work they're doing at the intersection of health and housing, and with Virginia Supportive Housing, a group that works with permanent supportive housing for homeless individuals, and again, bringing health supports to folks in that housing. So all of these are, not directed at seniors, but I think all have implications for seniors and groups that are working with seniors. I know my time's about up, but I want to just say a couple more things. One is, as I've said before, before I took this job, I was the president and CEO at another health conversion foundation in Phoenix, Arizona, and then spent 6 years working with David at Kresge Foundation. And the one lesson I've learned, and I'll just reiterate, I've said it a couple times, is no matter how big you are, and obviously Weinberg and Kresge and Ford and MacArthur are infinitely bigger than we are, but I think you can have an impact. And I hope those of you who are with philanthropy and are listening will recognize that. And I hope those of you who are providers and looking for philanthropic resources will recognize that even your smaller foundations might be able to help you out. And so I just offer a few quick things that are more related to philanthropy broadly than they are about housing or health. One is working with funders is all about trust and relationships. So you've got to build those relationships. And I think one of the best ways to build those relationships is to bring your knowledge to the funder. You don't have to go to them first about asking for money. You can go to them and say, here's what's happening in my neighborhood. Here's what's happening to the people I see and work with every day. And I think that information for most philanthropies is really important to understand. They can't be everywhere. They can't be on the ground. And I think it's critical. Remember that funders, that philanthropy is more than just about grants. Grants are obviously critically important, but as I mentioned, PRIs are another source of resources, but also they can be neutral conveners when you're trying to solve a problem in your community. And they can bring expertise either from within their organization or help purchase that expertise, whether it's around research or data gathering or whatever it may be. And then it's no secret that there's a power dynamic between providers and funders in most cases. You just have to work through that. Funders need to get better at that also, but I just encourage you, just confront it if necessary, and recognize that your knowledge and your experience and the involvement you have in the community is just as important and just as powerful in terms of information as what funders have. And then finally, help funders in your community understand that if they're not funding housing directly, they still housing is critically important to their outcomes, whether it be health or education or workforce. Their outcomes are critical because stable housing is critical to each one of those. And so again, even when you're working specifically with older adults, all of those play in, and funders sometimes forget that those outcomes are driven often by stable housing. So I look forward to answering questions later on, and I'll turn it back to Diane.
Fred, thank you so much. That was those just wonderful advice, wonderful thoughts. I do want to comment. You were apologizing at the outset for being small at 75 million. Well, I would love to have your size of endowment and be able to give out 3 to 4 million per year. I think it's all relative, isn't it? But I think you raised another point, which we can talk more about later when we get into discussion, is philanthropy isn't just about giving grants. We don't have enough money to solve all the problems in our communities. And so we are all engaging in much higher levels of advocacy and convening and partnership building and leveraging other resources. So thank you for hitting that point, really key. Okay, last but not least, I'm gonna turn it over to David, who's gonna share some information on the work he is doing to broaden health and housing outcomes through the Kresge Foundation. David, it's all yours.
Thanks, Diane. And I also want to thank Dwayne Spencer for inviting me. This is actually my last hurrah, at Kresge in a kind of an official capacity. Tomorrow is actually my last day at Kresge. I'm retiring after 30 years in philanthropy, the last 20 or so at Kresge itself. So I hope Diane and Dwayne and my fellow panelists don't mind if I philosophize a little bit, as I walk out the door, on this. But I thought I would talk about three big buckets. So like one is a little bit about Kresge, and then how did Kresge get to this intersection between health and housing? Because I led the health program for a dozen or so years when I was at Kresge, and then finally some big overarching maybe lessons, to pull out. And what I would like to maybe follow up a little bit on what Diane and the other speakers were saying. It is hard to follow Weinberg and even Fred Karnas. For those of you who know Fred, he's very modest and self-effacing, but he had a long career also, as a public servant when he was at HUD. And so he's been around the block, and I've learned a lot from him when he was here at Kresge. But there was something that, I learned actually 25 years ago that I want to modify. So an old Ford program officer was famous for saying, you can't buy change, but you can rent it for a while. And I often thought about that over the last 3 decades in philanthropy, and I kind of came to agree with that. But I actually have a modification, and that is that the idea of buying change is actually the wrong metaphor. It's investing in it, because what I have seen over 30 years is that if you invest in change and are faithful and patient with it, change can happen. And it may not be the sustainability of your program, but it may be change in the way policies are set, change in the way people think about those issues. And the example I often give is that of either the Ford Foundation itself or the Kellogg Foundation. Some of you may know that the Kellogg Foundation, since its beginnings, was focused on food systems. And the very fact that today we think about local food systems and organic food and sustainable agriculture is because of all the investments of Kellogg and many others, but Kellogg, certainly, and have us thinking very differently about food. That is the result of philanthropy. And I have seen the change in how philanthropy even thinks about housing, and I'll get to that just in a second. But a little bit about Kresge. Kresge, as many of you know, is a national foundation. We have, I've heard last, about almost $4 billion, despite the pandemic, which some people may seem obscene, but that's the way the market has gone. And we have 5 national programs. Health is one of them, human services, education, which focuses on higher education, environment, which focuses on climate change, and arts and culture, which focuses on creative placemaking. And we also have a community development program, which is focused in Detroit primarily. But we also have, in addition to the national programs, that we have place-based programs. And Detroit's kind of at the center of that. But Memphis is one of the cities that Kresge also focuses on, and many of you maybe even know of the work that is being done in Memphis. Along with Memphis, there's New Orleans and now Fresno. And the difference is that the national programs really focus on their respective fields of influence, where the place-based programs look to comprehensive, inclusive development in the places in which they're in many ways incorporating all those different kinds of fields in place. Because how development happens in a place is both a mixture of the evidence-based and the policy-based kinds of work, as well as the internal culture and politics of the place, and that's kind of what the place-based programs are about. So that's a little bit about Kresge, but when I took over the health program, many of you may not know the long history of Kresge, but Kresge in the beginning and for over 80 years was basically focused on capital grant making. That is, we made grants for bricks and mortar, and for many years, Weinberg and Kresge were one of the few foundations nationally to really do this kind of work. And then in about 2006 and 2007, there was a historic change with new leadership, and I got to be a part of that. But the interesting thing about that was that we essentially had to start new national programs, field-based programs, literally within a year. And I had tens of millions of dollars to dispose of, in that first year without Kresge having any prior work, in a field-based context. And one of the decisions we made very early on was that we were going to focus on social determinants of health. We weren't going to go to healthcare, health coverage, and access kinds of issues, which a lot of foundations, for good reasons, do, because certainly there is huge need in that area. I don't want to discount it, but at the time it was emerging this idea, it had been around for many, many years, but had begun to emerge as an important way of thinking about health. And that is that your health is influenced not less by your health care, but by the zip code you're in. And we took that to heart, since Kresge itself is really about expanding urban opportunity. And so that gave us a context to sort of think about this. Well, how do you produce health, in an urban opportunity framework? You begin to think differently about it. And I have to put out in front that in addition to all the things that we know about social determinants, that race itself has been such an important structural and systemic root of many of those social determinants. And that goes back to housing. I often think of housing as the scene of the crime when we talk about social determinants. That is to say, where you live certainly determines how healthy you are, but where you live might also have been determined by sometimes implicit or explicit race-based policies that have decided where people are going to live. Segregation is a reality in this country, whether it's de jure or de facto, and that is, in many ways, the determinant of the quality of your house, the price of your house, and that kind of a thing. When we began to look at housing, one of the first things we looked at over 10 years ago was lead. And we were just starting out. We were trying to figure out what to do. And lead poisoning was actually something that seemed like a doable, conquerable kind of thing. It has obviously been going down in this country, but it still persists, especially in urban areas and where there's a lot of older housing. But to make a long story short, that beginning journey in lead poisoning led us to understand or to look at substandard housing and who was living in the substandard housing and what other kinds of sort of disease-causing factors were in housing, including dust and mold and even safety, especially for older adults. As you know, falls are one of the main reasons for death and injury for older adults, and housing has a lot to do with that. And so we began to look at healthy housing, but it led us further into the issue of why do we have this kind of housing? And there are many, many reasons, of course, but it led us to look at housing itself as a fundamental threshold determinant of health. And we eventually, we concluded that housing itself, not just the mold and the lead poisoning and things like that, but housing itself was such an important determinant that we had to look at that. And in 2015, Fred and I actually wrote a paper on sort of rethinking health and housing from a philanthropic point of view, which got published. So sort of providing a broader panoramic view of why these two sectors had to be connected. And at the time when we said this, there wasn't actually a lot of philanthropic investment in that specific kind of issue. There wasn't even a lot of health investment in housing at the time. I mean, there was some here and there, and we were reflecting that in the paper that we wrote. But it was just really beginning, because many foundations at the time were still sort of thinking of, at least the health foundations, were thinking of social determinants around an obesity framework. So healthy eating, active living. That was the primary structure that people was beginning to think of social determinants, because obesity itself is such a huge issue in this country, and the food we eat, and the places in which we live and move. But we said, but housing is more fundamental, because even what you eat and where you live and play are kind of determined where you live. And that's kind of fixed in place. So that's a long story short of how we ended up in looking at housing. But in doing so, we had to broaden the frame beyond a pure public health point of view, and realizing that housing is a broader part of a system. And to Fred's point, we realized that this was an issue in which not only philanthropic capital, but investment capital from not only a PRI, program-related investment point of view, but even an investment point of view, needed to be kind of re-examined, because how we think about housing in this country kind of determines the policies that play out because of that. So that is kind of how we came to the point of looking at housing. So some of the things that this led us into specifically, and some of this will sound repetitive since Fred I took some of the lessons, certainly from his long career as well as the work at Kresge, and helped replicate it in Richmond. But one of them, is looking obviously at how we deploy our capital, but also looking at how to leverage other sources of capital. And Dwayne mentioned at the top of the session how hospitals and healthcare, why they ought to be invested in this for all the good reasons that he said. And we began to ask some questions about what role health systems could play, not only improving the health of their communities at a population level, but what role they could play in housing per se, because children with asthma were showing up in emergency rooms. Children with lead poisoning were showing up in their clinics. This was all related to housing. And some hospitals, especially children's hospitals, were beginning to ask the more fundamental question, like, I cannot fix the children if I can't fix the housing. And this led us into some work around hospitals working with children especially, but sometimes with older adults, but how hospital clinicians can work with renters and landlords, et cetera, to improve the stock of housing. Big long story. But we also began to ask the question, like, what large role could hospitals play? And this led us into thinking about, one, their hospital community benefits. Some of you may know that nonprofits, hospitals anyway, are required by IRS to contribute to their communities. And we thought that this could be a source potentially for housing. And we were also beginning to see hospitals not only deploy community benefit dollars, but also their treasury and their real estate assets to get into housing development. And this is something that we have helped support in the beginning with some work, especially around the Center for Community Investment. But then, and I'll sort of end with this, it led us to ask questions larger within the health system, because we concluded about hospitals is that, yes, they have some money, but really, the money in the health system doesn't reside in hospitals per se, and they will tell you that. Not that they're poor, but the money is really within the broader health system, payment system, which led us to look at the healthcare insurance kind of world, especially Medicaid managed care. I don't know if I can post something to everybody here. So I just posted a report. One thing we began that piqued our curiosity is that managed care organizations obviously statutorily have to hold some cash reserves against their payables. But what we were discovering was that they also had a lot of other capital reserves as what is called risk-based capital held against the larger risk that any insurer faces, and that there are no statutes or requirements about what the risk-based capital amounts are. And what we were learning through some early investigation was that managed care organizations have many times more than they're required in terms of the risk-based capital. And so the report that I posted, in the chat is that we supported some work with Community Catalyst based in Boston to look at this. And they looked at North Carolina UPMC for you, which in Pennsylvania, and United Healthcare, which is national, and began to explore what were the possibilities of this risk-based capital for housing. In the case of North Carolina, I believe it issued an amount of something $50 million new dollars that they were going to make available for affordable housing. So, and United Healthcare has been known for a number of years to be a pioneer in this area. Just recently launched a new initiative in Arizona, Fred's old stomping grounds, called Home Matters, where they were leading a consortium of other managed care providers and health systems, including CVS and Aetna, to raise $100 million for affordable housing in the state of Arizona. So we know these things are happening, and we can talk a little bit more about that maybe in the Q&A, but I wanted to just, sort of mention those things because this is a potential new area, of capital, for housing. But I do want to end because I don't want to overemphasize the housing. I know that since you're developers, you're interested in this particular issue, but to me, the far more important thing is changing the conversation about housing in this country. And I have to mention Funders for Housing and Opportunity, which Fred and actually Weinberg, Kresge, Weinberg, Ford, MacArthur, formerly RWJ, and formerly Gates, and several other foundations, Annie Casey, have formed a funder collaborative around this idea that housing is a platform for broader opportunity, not only health, but social mobility and for education. One of the key focus areas for FHO has been narrative change, because the way we talk about housing is so commodity focused that we miss the larger picture of why housing itself is such a fundamental threshold for opportunity. And it is connected to so many other things. And if we disconnect housing from those other things, we fail to understand the centrality of housing and the importance of people's lives, whether you're an older person or whether you're just starting out life as an infant. So I'll just close with that and hope we can get to a vigorous discussion in the Q&A.
David, thank you. And thank you for philosophizing a bit. I think that was really great food for thought. And I'm learning so much this morning. Also want to say congratulations on your retirement. A bit envious. So enjoy the transition. Before we move into Q&A, Dwayne wanted me to share some information on a couple of initiatives in Tennessee that focus on this intersection between health and housing. So I'm going to move quickly. I'm going to be very sensitive to the time we have remaining so we can get some of your questions answered. But want to touch on just a couple of things, one being the Senior Trust statewide initiative, which I'll get to second, but also wanted to just mention a project that I'm really excited about that is launching here in the Nashville community that really bridges the health and housing component. Urban Housing Solutions is a nonprofit organization that provides affordable housing solutions ranging from duplexes to large complexes. And they've recently opened an intergenerational arts-inspired housing community with 3 different components. One of the units is a 55-unit building for low-income seniors age 62 and up. The complex also houses artists, families, and has dedicated commercial space that includes a bank, a Vanderbilt health clinic, behavioral health services, and some community space for other programming. But what's so cool is they have really integrated health, wellness, mental health, digital literacy, and intergenerational programmings into this complex, and have created partnerships with Vanderbilt Medical Center, mental health organizations, Comcast, and a number of other partners to keep older adults in their homes and connected to their community. And it's really in the infancy stage. We funded planning, development of a frailty prevention component that has been created by Vanderbilt. And this year is the first full year of operation, and we're funding implementation of both the frailty prevention component and a research component to begin collecting data and metrics to document the value of this model. So I just wanted to throw that out as something that's really in the infancy stage here. We're very excited, and hopefully we're on the cusp of creating a new model that can be replicated. On a statewide level, as Dwayne said, we Tennessee came into this windfall of $40 million. Started back, I think it was 2013, 2014, when the state recovered this money from a court case involving the dissolution of 2 nursing homes in Murfreesboro. And after about 2 years of discussion and a fair amount of controversy about how those funds should be used, the Chancery Court ruled that they be used to support services for older adults in the areas of transportation, oral health care, affordable housing, and legal services. And it was further stipulated that the projects be collaborative in nature with a statewide reach. So I'm part of this consortium that's been advising the Tennessee Commission on Aging and Disability and the Chancery Court on the administration of those grant funds over the last couple of years. It's been a really fascinating partnership between private philanthropy and state government. We're just starting year 3 of a 3-year grant cycle. And what's been really fascinating is how we're seeing all of these areas colliding. And the most common theme has been the relationship between all these programs and health outcomes. I want to specifically mention the housing initiative here because Memphis Habitat was the lead agency awarded for this effort and received approximately $13 million to implement a statewide aging in place initiative that provides home accessibility, modification, and repairs targeted to about 1,200 homes. In a nutshell, what they've done is they have established a network across the state involving 30 13 habitat affiliates that are participating and implementing projects in 26 counties. So far, 728 projects have been completed. Additionally, there will be 75 capable projects included in the Memphis community. And there's quite a bit of analysis going on to look at the effectiveness of these. Green and Healthy Homes Initiative is doing a comprehensive analysis. And we've also the state has contracted with universities across the state to evaluate do a third-party evaluation of each of these 4 initiatives. So, you know, I'm not going to go into detail about what we've accomplished, that's still evolving, but just kind of the bigger picture is what we wanted to look at were programs that were not just transactional, flooding the state with more services, but that really had transformational components, creating new partnerships, collaborations, and systems of care that could be sustained. You know, Habitat is, you know, a shining example of this, in that we now have 13 Habitat affiliates in Tennessee that have been trained and have developed the capacity to implement the aging in place model. And this is a significant, I don't know how familiar you are with the Habitat model, but, you know, it's typically volunteers building new homes. So this aging in place model is a real departure from what these affiliates have been doing historically. I can tell you it was a challenge on the front end, and Dwayne will echo that, I'm sure, to launch this program statewide, but these systems are now in place. And the same is true for the other 3 initiatives that have been launched through these senior trust funds. So I think it's, again, this kind of goes back to, you know, philanthropy, not just funding services, but helping to build infrastructure and systems that can be sustained. You know, now we're looking at how to sustain these programs long term. We've got the systems, and I'm not going to dismiss the need for funding, because that's very real. But I want to go back to a statistic that Earl shared in his early remarks, that only 2% of philanthropic dollars nationally are going to support aging specific projects. And, you know, that's really discouraging. It's, I guess I would say, almost appalling when you look at the growth that's occurring in this demographic. So I guess what I would like to kick back to our panelists before I open it up from the audience is, you know, how do we address that disparity in funding? You know, we've all talked about, you know, leveraging other sources, forming new partnerships, looking for other payer sources. But I think a piece of that has to be engaging broader participation by philanthropy as a whole to begin to address these needs. So I'm going to invite my panelists to rejoin me. And I'm not going to call you out. I would just like to hear, you know, if you'd like to kind of weigh in on this in addition to what you've already shared, just dive in.
Thanks, Diana. I'll just go because I went first in the questions, but I'm looking forward to the other answers as well. I think making sure that everybody is aware of how integral older adults are in all of the different other facets that philanthropies do focus on the lives of youths, on equity that David talked about excellently. When we're talking about housing and fixing up an older adult's home, it is a long-term investment, not just for the life of that older adult, which we've gone through in detail, but passing that home on to the next generation, to the community, even if it, you know, leaves that family, depending on whether that older adult is connected to family, whoever that goes on to. The equity of that home is really how communities build wealth, build build community. And that can be saved a lot of times with roofs that prevent further damage to the house, furnaces, which prevent folks from living there, but also from the house from being able to be maintained. So those are so crucial. And then we've seen examples countless times in the programs that we've supported of older adults don't just get their house safe and not fall. That's not the end of the reporting, the follow-up that we want to see. They become more engaged. Board participation in local community boards or neighborhood associations, the percentage of those boards that are occupied by older adults increases when you make it safe for them to get out of the home, putting in a ramp, different things of, there's anecdotal evidence, but there's also quantitative evidence of just those percentages increasing, and older adults connecting with the youth in the neighborhood and making the neighborhood feel safer, being out on their front porch and engaging in community activities. So if you're interested in youth, if you're interested in jobs, all of these different things, passing on the knowledge of the older adults for workforce development, then you have a piece and a role to play with older adults.
I would just add quickly, just to what I was saying before, I just think that you have to be sort of aggressive and relentless in terms of getting information about what you're seeing in your community around older adults in front of funders. They can be caught up in programs they've funded for a long time, sort of the new shiny thing that may be emerging, and you just have to get in front of them with the data, with the information, and make them aware that this is a significant community problem. And as Earl said, that it has impact beyond just that individual in family or household. So I just encourage you to get in front of them as often as you can.
Yeah, Diane, this is, there really is no simple answer to this this question, but I do think that that the conversation is going to change nationally eventually, because it has to. Just because as a population we are getting older, and I think the awareness of that is just going to grow. Having said that, there's a couple of things. I hope that we can have a conversation about older adults that isn't seen as a zero-sum game with younger adults, for example, or younger children, let's say. Because it often gets, over all the years that I've been in this work, seeing this kind of, one age group pitted against another is, to me, futile. And the fact is that houses that work for older adults can work for young kids as well, and we ought to be thinking about, housing more broadly. So I kind of think about that. The other thing is that, and I don't want to make anyone on the panel feel self-conscious, Fred, but we are older adults, and you begin to realize that the world is seen through the prism of younger people, and that everything is framed about younger generations, let's say, than us, and that older people do get marginalized. And so the issue of housing is part of that larger conversation about how older adults in general are marginalized in the society. And so part of that is going to be, I think, not just a housing conversation, but about a generational conversation about how we can be more inclusive of everyone. So when we talk about inclusion, it's certainly BIPOC populations, disabled people, LGBTQ populations, but also older people. So how can we have true inclusivity about people of all kinds, so that no one gets marginalized? And that's a very, very tall aspirational order, I know, but I think it's part of what the journey that we're all on.
Well, and I think, that really hits something real close to my heart. Our foundation has been involved in this national movement called Reframing Aging, to really change the narrative about how we talk about, think about, support older adults from both a community, a service, and a policy perspective. And we can't continue, it's not an us, them, it's all of us. Grandparents are raising grandchildren. Older adults are kind of the linchpin for volunteerism when, you know, they had to be furloughed when the pandemic hit because of their being in the at-risk age group. It really hit agencies hard to lose that volunteer workforce. So you're right, older adults need to be valued and considered when we talk about inclusion, because if older adults are supported, it's a benefit for the entire community. So thank you for raising that. I'm going to move to, there are a couple questions here from the audience. I know we're about 10 minutes out. Okay, so this one is, says, okay, this is to David. Earl said philanthropy can fund what the client wants, and Fred said philanthropy can raise awareness and address the intersection of health and housing needs as conveners. Can we also say fund what the data supports, and how could practitioners and philanthropy groups make a case to insurance like Medicaid managed care that this work is worth investing in?
Yeah, that's a great question. And there's actually, in the preparation for this call, I mentioned some things that that the evidence is a little bit mixed, actually. The National Academies of Science, Engineering, and Medicine actually had a consensus study, which we helped support, and Fred was part of that. And Fred, correct me if I get some of the broad details wrong, but it was based entirely on this idea that, yeah, if we invest in permanent supportive housing, we can actually save lives and save money, improve health and save money. And the data, at least that the consensus study committee looked at, is actually not conclusive. There's some good evidence here and there that it might improve or reduce costs, but it's not conclusive. So they weren't able to say there was a clear case for it, but and we argued with them actually about the results, because part of it is that when you're working with, whether you're working with an older population, or let's say a population, sort of the dual eligible population especially, or people with other kinds of conditions, et cetera, the kinds of supports you have are so varied and different from place to place. It's hard to compare across all these things, and what people do as interventions in a supportive housing situation can vary depending on the individual circumstances, et cetera. So you can't, there wasn't a one program fits all kind of thing that they could say this works. Having said that, it has not stopped health systems and managed care organizations from going ahead. And there's one group that it just says, it's our mission, we should do this. They're convinced that beyond the data, there is I don't want to say a moral, but certainly a kind of intuitive, case for moving forward. And others are pursuing this because they feel that they need to help build the evidence case. So I think that rather than saying the case is closed, is we just need more work, and people are willing to put the work into it, because it just makes imminent sense, and people can see the results. But when you compare it across thousands and thousands of cases, it doesn't always add up. Having said that, there are obviously individual programs that where the evidence is very strong, whether it's things like Capable or PACE, other things that I've come across with over the years. But broadly speaking, we're at the stage where it's really up to you all to press, because that does make a difference. If you believe in it, it's one program here, one program there, but then all your voices collectively actually do make a difference. So that'd be my response to that. And Fred, do you want to add anything?
No, I think you covered it well. No, it's good.
Okay, well, we're not going to get to all the questions. We are down to about 5 minutes, 6 minutes. So before I throw it back to Dwayne, I just want to throw out a closing question to everybody on the panel. You know, we've talked about a lot of different philanthropic approaches, some of the philanthropic disparities, but what should our priority be as philanthropists in this space other than funding?
I'll take the easy answer, and Fred and David certainly have more experience on this, and that's making connections of individuals who have good program ideas, know the community, are reaching out and talking to the actual older adults in the community. So facilitating collaboration and partnership. That's what really stood out to us with the 10 Care and Memphis Habitat and other partnerships that we've funded. And some of those come to us, but sometimes we're able to facilitate those linkages.
I would say from our perspective, one of the things that we look at is, are there ways that we can help identify best practices, evidence-based approaches, and either accelerate them in the community where they're already in place, or resource them in a way that they can be brought to our community. I think we know a lot of what needs to be done. We just need to do more of it, and where we don't know, philanthropy needs to be there to support the research and data collection that's critical.
I'd agree with both Fred and Earl on that. I would say I would add elevate lived experience, especially as we think about policies and even the design of facilities moving forward. Human-centered design, I think, is here, and we should support some of that work. And also, and for foundations, think about how you can use all of your capital more creatively, and whether you're even investing, whether some of your investments may be counter, to affordable housing. That is to say, are your investment managers investing in luxury apartments and leading to gentrification? I think it's a question that investment managers need to be very, very aware of.
And just quickly, somebody posted on the screen real quickly, advocacy, and I could not agree more that funders have to be comfortable with supporting the advocacy that's needed for the policy and practice changes that are critical. So appreciate that, whoever that was that posted it there really quickly. It was a really important point.
Well, Earl, Fred, and David, thank you so much for being part of this panel. I don't know about the rest of the group out there, but I have learned so much. This has been the best professional development I've had for months. So thank you for sharing all that you're doing, and thank you for doing all that you're doing. It is making a huge impact on so many people and so many systems, and really just so grateful. And with that, I'm going to turn it back over to Dwayne to close us out.
All right, Diane and panelists, thank you so much. This was extremely engaging and a very candid panel. Thank you so much. So some takeaways. Earl talked about sustainability, and that's what this conversation was about, how philanthropy can help in that. But he mentioned that most philanthropic funders don't want to fund something forever, and we know that. I loved David sharing that you can't buy change, but you can rent it for a while. And it's not about buying change, it's about investing in it. David also shared that housing is a platform for broader opportunity. That absolutely aligns with what we believe at Habitat. There's a need for us to emphasize also, I think, the tertiary benefits and impacts of our aging in place work. The senior benefits, of course, but so does the community. There's job creation because of the construction-related interventions, retention of property taxes because the senior remains in their home. And as we continue to point out, the healthcare savings are significant and the benefit to insurers and payers. Healthcare investment can come from evidence-based data, but it can also come from mission-integrated intent from the leadership of those organizations, wrapped in the framework that it's the right thing to do. And so at the closing, Diane asked an amazing question: what else can philanthropy do other than make contributions? And so what we heard was facilitate and linkage to partnerships, accelerate best practices to include data collection, elevate the lived experience, and then advocacy. And as we at Habitat for Humanity are moving into our annual Habitat on the Hill, that definitely rings true to us. Policy and practice changes are what's going to be necessary for sustaining this work. So what an amazing 3 weeks this has been so far. If any of you have missed any of the sessions, don't forget that you can catch up with them by watching the videos that we share weekly. Next week's going to be really interesting as we move to closing out these conversations. So the next speaker is Dr. Tiffany Manuel, who's president and CEO of The Case Made. So as we fondly call her Dr. T, she will take us through a series of steps and exercises and some recommendations for building public will and political will. And then you all will have an opportunity to interact with her via the Q&A. So that's going to be really, really interesting. And it will help us close out this conversation with the intention, as we've said from the very beginning, with the intention to move from research and conversation to action and implementation, and hopefully sustainability of the work. So please go to our website or the PDF program to read more about Dr. T, and you'll find her book, Strategic Case Making, The Field Guide to Building Public and Political Will, on Amazon, if you'd like to order it before the session. So be on the lookout for our email, and we thank you all for just joining us and digging deep into these conversations. And we can't wait to see you next week as we close out our Health and Housing Summit. Thank you for joining us and have a great rest of the day.